Okay, our next speaker is our own Executive Director, Dr. Mark Schulz. Many of you have seen him on our channel. He's a world-renowned medical oncologist with over 30 years of experience treating all types of prostate cancer. Dr. Schulz is the founder of PCRI and has dedicated his life to making sure prostate cancer patients and their families have access to free education and a focus on better quality of life. Today, he will be giving us an overview of treatments in advanced disease. Here is Dr. Schulz.
We're going to cover an overview of advanced prostate cancer. Advanced prostate cancer is becoming, thankfully, less and less common. We're getting better and better at preventing advanced prostate cancer. But it is an entity unto itself. There's a group of people that develop metastatic disease and need special care. And this talk is going to give an overview of that situation. Only an overview because obviously there's a lot of information, a lot of detail that we can't cover. But I think an overview will be useful because you don't want to miss out on something obvious. So we're going to go through and cover the basics and hopefully put it in perspective so people will know how to prioritize the different decisions that they need to make. When you talk about advanced prostate cancer, it is a little ambiguous because if the disease is coming outside the prostate gland, locally advanced prostate cancer, that is considered a serious development, especially in the historical sense where everyone was getting surgery, because the surgeons wouldn't be able to get all the cancer out. We are learning, however, that some degree of spread outside the prostate is not invariably associated with spread to other parts of the body. We call that metastasis. And it's the metastasis that really drive the storyline. Without metastasis, with a number of modern tools, radiation in particular, disease that's outside the prostate and that hasn't spread to the rest of the body can usually be cured. So it's the metastasis or the absence of metastasis that defines whether or not we have advanced cancer. Now, certainly there are different types of advanced cancer, and there's a lot of different staging systems. But in simplistic terms, you're going to define these differences based on where the cancer is, and of course, how much is out there. The number of metastases will be important. But are they only in the lymph nodes? Have they spread to the bone? Or most serious of all, have they spread to the liver? This constitutes very different types of advanced prostate cancer. The other thing that defines advanced prostate cancer is how the cancer has behaved under the duress of different types of treatment. If treatment responses result in complete remission, then obviously that's a less worrisome type of cancer. The cancers that progress through our best treatments, radiation, hormone therapy, chemotherapy, are more serious types of advanced prostate cancer. And we're going to elaborate on these themes as the talk goes on. So our main tools for treating advanced prostate cancer are hormone therapy to block testosterone, a very effective form of treatment, different types of chemotherapy, radiation therapy, which can be delivered through an invisible beam at targets in the body, immunotherapy, treatments to stimulate the immune system to attack the cancer, and then different forms of injectable radiation therapy into the bloodstream that circulates around and attacks the cancer at its different locations in the body. Historically, we've always started off talking about hormone treatment and chemo treatment, and the idea of radiation treatment being a priority as treatment for advanced metastatic prostate cancer hasn't been on the table too much. We've always had the technology to do it, to give invisible beams of radiation to metastatic sites, but our imaging studies were so poor that we knew we were only treating the tip of the iceberg. This has changed with the advent of PSMA PET scans. And with these types of new scans, we are seeing 80 to 90% and sometimes 100% of all the cancer that's visible. That opens the door to utilize very accurate beam radiation to eradicate metastatic sites. So the types of scans that have been historically used are called T99 technetium scans. And you can see a picture of sort of a blurry picture on this slide that represents the rather poor quality that was available previously. There are better F18 PET scans, but those scans are not disease specific, and if someone kicks you in the shins, they can light up and falsely show what is thought to be metastatic disease. Disease-specific PSMA PET scans and, to a somewhat lesser degree, Axemin and C11 choline PET scans are much more disease-specific and only light up, in general, for prostate cancer. FDG PET scans have been typically used to detect other types of cancer, lung cancers, lymphomas, but in some cases will pick up particularly aggressive types of prostate cancer when it's in its very advanced stages. So as we talked about before, not all types of advanced cancer are the same, and the number of metastases is one way to look at how serious the situation is. There's been a threshold of 5 or more metastases versus 5 or fewer than 5 metastases as defining less serious and more serious types of metastatic disease. We already pointed out that the men that have lymph node disease only have a much better prognosis than those that have developed spread to the bone, and those men have a better prognosis than disease that spreads to the liver. And response to treatment, which we alluded to previously, can be measured by whether or not the PSA goes all the way down to undetectable levels in response to treatment. And now with these better scans, we expect the PSMA PET scans in particular to show disappearance of disease activity if the treatment is effective. Men that don't get complete disappearance or who can't get their PSAs down to less than 0.1, that would be the appropriate PSA nadir, have a more worrisome type of cancer. So when we talk about radiation treatment, there's a lot of confusion about what's actually going on. Many of my patients seem to envision a heat beam that's burning cancer cells in the pathway of the beam, and this actually is not at all accurate. The radiation damages the coding inside the cells, the DNA, and the cancer cells actually continue to function until the time when they want to replicate. And when that happens, because they have messed up software, that's when they die. And when people undergo treatment with beam radiation to a metastatic site, it may take several months, 6, even 12 months, before you'll see the PSA decline completely. Sometimes it takes a little patience after radiation is administered to a metastatic site to see results. When I'm talking about radiation for metastatic disease, as I mentioned before, it's the PSMA PET scans that have brought this about. The technology for giving accurate treatment has been evolving over the last 20 years, just for historical reasons. Seed implant radiation, where the radiation is put right in the target, not usually used for metastatic disease, is obviously very accurate because the doctors are visualizing exactly where the radiation is being placed. IMRT, or intensity modified radiation, came around 2005. SBRT, which is a much more rapid form of treatment, became popular around 2015 and forward. And in particular, these treatments, when administered to the prostate gland, have become much safer due to the development of techniques such as gel between the rectum and the prostate. But repurposing these treatments, brachytherapy, IMRT, and SBRT, to treat metastatic disease was always feasible if we had clear sight of what we wanted to treat. And the technology to treat prostate glands has been evolving now for 20-25 years. It turns out that treating metastatic sites, in most cases, lymph nodes or a spot on the bones, is very easy for a radiation therapist. These targets can be easily visualized on a PET scan, and therefore the cancer can be completely sterilized in the target. So radiation therapy, which was very much in the background for metastatic disease until the recent advent of PSMA PET scans, now is becoming a very prominent player. Now I'm going to talk just briefly about some of the other treatments besides radiation, and then we'll try and see if we can show how one selects amongst these different types of treatment. So hormone therapy is an acknowledged, very effective form of treatment, and it can play several different roles. If you give hormone therapy in combination with other treatments, they can have a synergistic effect. 1 + 1 can equal 3. So hormone therapy does synergize with radiation. It does synergize with chemotherapy. Hormone therapy has been a mainstay for treating disease that we couldn't see because the scans were so poor. So as an insurance against possible small bits of cancer that were not visible, such as what we call so-called micrometastatic disease, hormone therapy was often administered as a panacea to cover that eventuality. But the mainstay for hormone therapy has always been to treat men with known metastatic disease, and it can be very effective. It tends to be somewhat more effective in lymph node only disease, and it can be very effective in metastatic bone disease, but will not be as universally effective as it is with lymph node disease. So here are some of the names of different types of hormone therapy, and as people consider embarking upon the treatment, there are really two main categories. Medicines such as Lupron that block testosterone coming from the testicles, and medicines such as Zytiga, Xtandi, Erleada, or Nubeqa, which block testosterone that the tumor itself can produce. To get maximum anti-cancer efficacy, the typical policy is to use one of these medicines from each of these categories to bring about optimal remission rates. When we talk about chemotherapy, Taxotere, otherwise known as docetaxel, has been on the market since it was FDA approved around 2004. Jevtana is a very similar medication. Carboplatin is a type of chemotherapy typically used for lung cancer, ovarian cancer, that also has efficacy for prostate cancer. The other category of chemotherapy for prostate cancer is called PARP inhibition. And these medicines are only going to be effective in about 10% of men that have prostate cancer. This is who these 10% are is determined through genetic testing, which we'll go into. So there are 4 products on the market right now, Lynparza, Rubraca, Talzenna, and Akega, that work through a mechanism of PARP inhibition. How does one know if he has the appropriate genetic mutation for PARP inhibition? And that is a fairly simple process. A blood test such as Guardant 360 or Foundation 1 can detect micro bits of DNA that are floating around in the blood that are released by the tumor cells. And the mutations are diagnosed via that means, and if they come back with a mutation such as a BRCA1 or BRCA2, the likelihood of those PARP inhibitors being effective is very high. One other thing that DNA testing with Guardant 360 or Foundation 1 can accomplish is to detect another rare mutation called microsatellite instability. In these patients, an immune medicine called Keytruda has very high response rates and would be the treatment of choice for that individual. There are other mutations that can be detected through this genetic testing, and we'll talk a little bit more about that later in the talk. Immunotherapy, as we already alluded to Keytruda, the FDA-approved so-called vaccine for prostate cancer called Provenge came out around 2010 and is an effective medication for men who are in developing resistance to Lupron. Radiation therapy to metastatic sites has an additional benefit beyond simply killing the tumor in the target region. When those tumor cells die, the immune system comes in and sweeps up the debris and learns about that cancer in a way that allows it to attack cancer cells in other parts of the body. This is called the abscopal effect. So there are two benefits from spot radiation, one being the destruction of the tumor that's being targeted, and the other is a stimulating effect on the cancer cells, generally speaking. Other immune therapies, such as ipilimumab, are rather effective in certain situations. They are unfortunately not yet FDA approved, and cost can be a barrier. But there are good studies showing effectiveness in advanced prostate cancer. When we talk about Provenge, the vaccine that administers a boost to the immune system, the methodology used is rather unique. There are dendritic cells in the blood that detect and multiply and stimulate our immune systems to go attack invaders. Dendritic cells, through this treatment, are removed from the body and stimulated at a special facility and then re-administered to the patient to cause their immune system to attack the cancer. This particular study points out that immune therapy tends to work much better when there are fewer cancer cells. This is a principle of all metastatic disease and even earlier stage prostate cancers. And the amount of survival advantage observed in patients that had high PSAs over 134 compared to PSAs that were less than 22 when they administered the Provenge to them, showing that there was a 3- or 4-fold greater improvement in survival. This was further elaborated in another larger observational trial showing that when this immune therapy was given to metastatic disease in men that had PSAs less than 5, that their survival was augmented quite a bit more. This brings about the whole issue of how do we utilize all these different tools in the most effective way? The medicines that are available all potentially come with side effects. And one could envision a favorable scenario where all these medicines had no side effects at all. And for safety reasons, and anti-cancer effect, we would just give everything together up front. That could be more costly, it could be more toxic. So there has been perhaps a policy reacting against overuse of medicines that typically has relied on a sequential approach where people after diagnosis first have an operation to remove the gland. If the PSA rises, radiate where the prostate used to be. If the PSA rises, give some hormone treatment with Lupron. If that stops working, administer some Provenge. If that doesn't keep the disease in check, take some chemotherapy, or the most common type of chemotherapy called Taxotere. If that doesn't work, try a PARP inhibitor such as olaparib. If that doesn't work, perhaps an injectable radiation such as Pluvicto. If that doesn't work, go on and have a clinical trial. It's rather surprising to me that this one after the other approach is by many thought to be the only way to treat prostate cancer. And that's certainly unfortunate because there's good evidence that will show shortly that combinations of treatment up front can be more effective. So what are the advantages and the disadvantages of this sequential versus combination approach? The sequential approach that I just showed you it's an established approach. People are comfortable with it. When you only take one treatment at a time, there are less side effects. Some doctors are comforted by the thought of having some more treatment held in reserve. Since this is the standard approach, insurance typically will cover it. And prostate cancer can be very slow growing, and if a person is more elderly, they will die of natural causes before they run out of options. The problem with that approach is that if the treatment is not curative, we give the cancer an opportunity to develop resistance to that treatment. And it's possible that the disease that is left after leapfrogging over that treatment is it will become more aggressive and more difficult to treat as time goes on. So the advantages of using 2 or 3 treatments together in combination at an earlier stage is that the treatment, of course, is more potent. It will result in higher disease control rates, longer survival, and if we can reduce an admission that allows them to go off hormone therapy, their quality of life could even be better. The downside is more side effects when combination treatment is administered. I think the best way to illustrate the interplay between these 2 different treatment approaches is to simply describe a case. A man that was diagnosed back in 2001 at the age of 64. He had a Gleason 9 with a PSA of almost 5. He was treated with radiation therapy to the prostate. Unfortunately, 2 years later, his PSA was up to 15, and an MRI showed that he had a metastasis in his hip. He went on standard hormone therapy for that era, which was Lupron and Casodex, and then had radiation to the hip. Now, in 2005, that was definitely unorthodox, as there was really no established policy of giving radiation to metastatic sites back then. But there didn't seem to be too much downside, and as things have turned out, it seems like he may have benefited. In addition, he was also given a short course of chemotherapy called Taxotere. This put him in remission for if we do the calculation here, about 8 years. But in 2014, his PSA started to rise, and a back then newer form of PET scan called a C11 PET scan showed a new metastasis in his rib. He had radiation to the site on his rib. This is starting to pick up popularity, giving radiation to metastatic sites, and was put back on hormone therapy. His remission was rather brief, and when his PSA rose up again in 2016, he was reinstituted on hormone therapy, Lupron and Casodex. And unfortunately, his PSA started to rise. And this was occurring at a time when he was on hormone therapy. So we are talking about hormone resistance. This is the typical window when Provenge or immune therapy is covered by insurance, and he underwent that therapy. He also started on a second-generation form of hormone blockade, the type that can block testosterone inside the cancer cell, called Xtandi. He also was noted soon thereafter to have a metastatic site in his lymph node near the lung. This was biopsied and confirmed to be cancer, and so radiation was administered to that spot as well. These more recent treatments then resulted in a complete remission, and in 2022, after having a low undetectable PSA for a very extended period of time, he stopped his Xtandi treatment and started on testosterone. Being as elderly as he was, at this point he is in around 80. His testicles had been in remission for so long that he was unlikely to ever make testosterone on his own. And for quality of life reasons, he was put on testosterone. Now, of course, we have PSMA PET scans, and when he started getting testosterone, his PSA rose up to 2.1 in October of 2022, but his PSMA PET scan showed no metastatic disease. He had a further rise in PSA up to 2.2, and so in May of 2023, another PET scan was also clear. What we've learned is that there are about 10% of patients with advanced prostate cancer who are not going to show up on PSMA PET scans, and so he underwent another type of PET scan called an Aximum PET scan in June of 2023, which was also clear, generally reassuring us that his cancer situation, despite the rise in PSA, showed no imminent danger in this now 81-year-old gentleman. Now we are left with a situation where he's feeling much better on testosterone. His PSA is rising, but he has no detectable disease. We're thinking of getting either a C11 or maybe an FDG PET scan to make sure he doesn't have some strange metabolic variant of prostate cancer. For now, we're going to keep him on testosterone. And it looks like I did a bad calculation on the age. Actually, he's 86 now. So when we're looking at the decision making about giving combination treatment versus sequential treatment one at a time, studies have been done looking at survival outcomes in people with metastatic disease. there are two main categories that we look at for trying to decide how to administer combination therapy. One is in people who show up at the doctor and already have metastatic disease at the time of diagnosis. We call this synchronous metastasis. So they clearly have disease in their prostate. They also have disease that is somewhere outside the body. Studies that have been done looking at giving just Lupron versus adding some other effective medication as listed in the column on the left, Zytiga, Taxotere, radiation, Xtandi, or Erleada, all show better survival if instead of waiting for the Lupron to run out of gas, the men get a combination of Lupron plus Taxotere or Lupron plus Xtandi, Lupron plus Zytiga. Those men will have better survival and live significantly longer. It's not a big surprise, really, because giving more potent treatment to less established disease is, of course, very likely to result in better outcomes. More recently, in 2022, studies have looked at giving so-called triplet therapy. So if Lupron plus Taxotere gives better outcomes, does Lupron plus Taxotere plus Zytiga give even better outcomes? And the answer to that question is yes, it does. Since these different treatments all work by different mechanisms to attack the cancer, the comparisons between giving Lupron and Taxotere alone versus Lupron, Taxotere, and Zytiga show that the latter group has better survival compared to the former. Now remember, these former groups, they will get the Zytiga at some point down the line. It's not like they're denied the treatment. It's just a matter of timing. So getting all three medicines immediately versus two medicines now and the third one later, by postponing that third one till later time, results in shorter survival. So since we know these facts, these are large randomized studies published in very reputable journals. Some questions arise. If giving all three medicines is beneficial, aren't there certain more favorable types of metastatic disease that maybe can get by with just two and have less side effects? It seems that they're leaning towards thinking that it's the men with lymph node only disease who maybe don't need the Taxotere. They can get by with just the Lupron and Zytiga. Another question that arises now that we know in that 10% of people that have BRCA mutations, maybe taking something like olaparib instead of Taxotere would be a logical substitution. And then the last question comes, in men that have these metastatic disease situations, when they get complete remission, when their PSA goes all the way down to zero, when their PSMA PET scans show disappearance of all activity, how long do they need to remain on Lupron and testosterone deprivation? The studies at this point are not completed, but it appears that after perhaps 2 years of treatment, that further ongoing treatment in people who are in a complete remission may not have any durable benefit as long as they're monitored when the treatment is stopped. Now, when we think of metastatic disease, oftentimes it's another situation where men have disease that was treated with radiation or surgery at some time in the past, and now there's a rising PSA and metastases are detected on a scan. The idea on how to manage these men, of course, is very different, because a disease that takes 3 or 4 or 5 years to show up after the radiation or surgery sounds nowhere near as scary or dangerous as one in which the man is diagnosed and has disease already all over his body. So it's becoming more popular now to use a more minimalistic approach if there's, say, only 1 or 2 lymph nodes, to simply treat those lymph nodes with some radiation, maybe with a short course of testosterone blockade. When men have multiple spots, then the typical approach would be to regress to the triplet aggressive approach that gives maximum anti-cancer treatment effect. After a person has been in this war zone for a while, there are going to be some individuals who develop resistant disease to the things that we've talked about, to immune therapy, to hormone therapy, to chemotherapy. And that brings about not an uncommon situation as to what do you do next. Well, fortunately, there's a recently FDA-approved radiation treatment that is kind of like a smart bomb. It can be injected into the bloodstream and find all the metastatic sites and treat them with potent radiation called lutetium-177 or Pluvicto. This is very well tolerated, the most common side effect being dry mouth because there's some spillover effect on the salivary glands. And it also can cause low blood counts. Prior to lutetium being on the market, we had another injectable form of radiation treatment, radium-223, or so-called Xofigo. The disadvantage of the Xofigo is that it would only cover spots on the bones. Lutetium will cover spots anywhere, whether it be in the liver, the bones, the lymph nodes. Xofigo is still a useful treatment because bone-based prostate cancer is common. It's also an injectable form of radiation. An interesting treatment that gets a lot of press and in my experience has not been that effective, but it can be effective, is to re-administer testosterone to men who have had low testosterone for a long time and now they're becoming resistant to the low testosterone therapy. In this case, men are given an injection of high-dose testosterone on a monthly basis, and for some reason, that can confuse the cancer and people can develop remissions. The reason I mention it also is, of course, these men that have been deprived of testosterone for many, many years are tending to feel much better getting their testosterone back, and this type of treatment gets a lot of attention. In my experience, the remissions are not particularly durable, and there is a risk that the testosterone can stimulate the cancer, so men have to be monitored very carefully. I said I was going to come back to genetic testing because sometimes in the course of genetic testing, they find a mutation that mimics mutations seen in other cancer types, maybe lung cancer or pancreas cancer. And there are treatments that have been developed for lung and pancreas cancer that are based on a genetic weakness in the cancer cell. So while it's not proven that that same medicine in prostate cancer will be effective, it's logical to assume that it may, and genetic testing sometimes will point to a treatment that's FDA approved in another cancer type that could help out in prostate cancer. And then the last form of treatment in this situation where people have become resistant to all the known FDA-approved treatments is to pursue investigational trials at academic centers where new medicines are being studied. That is, again, the same diagnostic test, Garden 360 or Foundation 1, which other mutations are sometimes detected besides the ones that we're looking for in prostate cancer, such as BRCA. So in wrapping up this overview of metastatic prostate cancer, advanced prostate cancer, the landscape is changing so quickly, it's critically important for patients to be educated about all these different options. There's also an unevenness in the delivery of care. Some centers specialize in prostate cancer, others are doing it more in their spare time. And the physicians these days are very busy with all the new developments in all the different cancer types, and it's important to get to physicians that are for whom prostate cancer is a mainstream pursuit. As a baseline, if you look at people who are going to do better or worse, those that pursue strength training and keep their muscles strong, those that stay away from animal protein, this is for the advanced stages of prostate cancer. There are medicines to support bone health because loss of testosterone can cause weakening of the bones, and medicines such as Xgeva, Prolia, and Zometa can counteract that. There are ways to detect who is going to have immune side effects from radiation or Keytruda through a diagnostic test called Prostox. There is a pill that can prevent breast enlargement, a common accompaniment of men who are taking testosterone deprivation. And lastly, it's always routine when we administer Taxotere to use a medication called Neulasta, which stimulates the immune system. I have seen a number of patients treated at outside facilities that for some reason their physicians wait until an infection occurs before they start giving the immune stimulating medicine. Neulasta is covered by most insurances, and it typically has no side effects, and I think patients need to be aware that this product exists and request its use routinely whenever Taxotere is being administered. What do we have looking forward? I think what I've described to you today is a forward-looking approach to prostate cancer. I'd say the one thing on the horizon that looks exciting is an enhancement of injectable radiation called actinium. Lutetium-177 has been a big breakthrough. We're very excited about it, but if you look at the responses in men with very advanced disease, perhaps a third get fantastic responses, a third get stabilization of their disease, and another third start to have progression soon during or soon after the treatment. I've had 2 patients in whom actinium seems to have brought about durable remissions in men with otherwise very advanced disease. It's quite a bit more toxic, however, and it's not yet FDA approved, but it is available on clinical trials. The future for treatment of metastatic disease is going to be partly preventing metastasis in the first place, and that occurs through earlier diagnosis and more aggressive treatment, combination treatment up front. The exciting thing is that there are many, many new discoveries coming out due to the vast amounts of funding from both private and government sources. Prostate cancer is the most common cancer in men, and it's a huge marketplace, and research is progressing very rapidly.
Hello, look who I have in the hot seat. I mean, super hot seat, right? Usually we're doing Zoom together and we're not in the same room. So isn't it incredible that you're in the same room with me?
It's delightful here in Marina del Rey. Yeah. I showed a picture of the place where we're staying, and it's been a great weekend.
It's been great. So we're gonna do a little thing I call Dr. Moyad's Pro and Cons with Dr. Scholes. So we're just gonna look at a lot of little subjects, and I wanna know the positive and I want to know the negative about these subjects. And then the rest of this we do on Zoom. We've got a whole other big conference session on Zoom. So are you ready?
Ready.
All right, here we go. First of all, I can't, and you talked about this in your talk, I can't stop talking about bone health. And the reason why is because of a paper we brought up, and we talked about at the last conference. It was actually a men's health conference, that when they did a survey of all the men on androgen deprivation therapy, less than 10% of them were getting DEXA scans. So 9 out of 10 men aren't getting standard of care in terms of seeing whether or not they have osteoporosis before, during, or after getting hormone therapy. They actually came out with the number 8%. I think that's almost being generous. Will you comment on what is the problem of getting a bone mineral density test right before or during the time you're on androgen deprivation therapy? Why isn't this standard protocol?
Well, I think prostate cancer is unique because it's being managed primarily by surgeons, by urologists, where medical oncologists are taking care of all the other types of cancer. And if you look at modern treatment of cancer, there's been a huge shift in the last 40 years. If you go back 40 years, everyone was getting surgery to have tumors removed. And if you look at it now in 2023, it's mostly about medicines. And medical care has been in the domain of the internal medicine doctors and the oncologists, whereas surgery is in the domain of surgeons. If you look at medical treatment for advanced prostate cancer, just as we've reviewed, a lot of it's just different types of medicines. Why are surgeons doing that? It's just the way it's always been. And unfortunately, very obvious and necessary things are being overlooked on the day-to-day management of men with advanced prostate cancer. So I think the take-home message for patients that are in this situation is look for a medical oncologist to manage their advanced metastatic disease. Don't stay in a urology office and get your primary care from a surgeon.
But there are all these bone drugs that you've used in your career. I call them bone protecting agents, right? How do I know if I'm supposed to be on one or not? because they are approved for men with advanced disease under certain conditions. Why aren't we talking about this more at the conferences and other places? Because, here's the question. Who do you put on these bone drugs? What are the drugs and who do you put on them?
Everyone who is on a testosterone blocking agent.
Okay.
Any Lupron or any of its similar types of medication, any Zytiga or similar types of medication, these men are all known to have accelerated calcium loss and high incidence of osteoporosis, and it can be prevented with the medications that you've listed.
So you're more likely to lean putting someone on there what if they're not going to be on hormone therapy indefinitely? They're just going to be on it for a short period of time. Do you still lean toward giving them a bone protecting agent?
It's a good question, because now with the advent of PSMA PET scans, we're giving more and more short course hormone therapy for only 6 months. And I think your point of why don't we get a scan and see if they are already depleted, then we certainly would be putting them on treatment. But if they've got robust, strong bones, and we're only going to administer the treatment for 6 months, perhaps just observe it and check again. We check bone density tests in all of our men, not just the ones that are getting hormone blockade, because bone loss with age is common, and hip fractures in the elderly are disastrous. It's a simple test. The exposure to radiation is minimal, and therefore should be routine, probably in men that are over 70, to get a bone density test.
And the bone drugs that you give, do you give the injectables? Do you give the orals? They come in a variety of forms. Which type do you like?
Patients actually could probably pick the ones that they like. The orals, such as Boniva and Actonil, are a once-a-month pill. The injectables are convenient because you can take a shot every 6 months. The injectables often are covered by insurance, whereas the orals may not be, so you can save money with an injectable. But I think they're all relatively equally efficacious, and they are generally well tolerated, and I don't have a strong opinion in terms of one approach over the other.
Do you remember long ago, it was for this conference, long ago in my mind means 5 years ago now, it's not very long, where people thought the bone protecting agents might prevent metastatic disease. They thought they could protect from the cancer going into the bone itself. Where are we with that philosophy? Do we have any answer to that?
It turns out that with really high doses of denosumab, or so-called Xgeva, that they could delay the onset of bone metastasis in men who were hormone resistant. About 20% delay in the onset of bone metastasis. It didn't get FDA approved for treatment for that role because there was a lot of osteonecrosis when men were getting denosumab shots every month. So high doses cause jaw problems that are really nasty. So it has been proven in a double-blind randomized placebo-controlled trial that these medicines do indeed prevent the onset of metastasis to some degree, but in high doses it comes at a very high cost.
Yeah.
So we've taken sort of a middle road in using these medicines, but at the same time cutting back to maybe every 3 or 4 months for the injections rather than monthly, to try and get the benefit, hopefully, without inducing the problems with the jaw necrosis.
So you're not giving them that often, but they're clearly effective even when not given that often.
Yeah, I mean, people could argue that technically there's no proof that lower doses will translate into the same benefit that was seen as higher doses.
Yeah.
But the dangers of higher doses just are just unacceptable in my view.
I want to leave that topic unless there's something else you want to add about bone health.
No, the fitness, a little bit of calcium at bedtime, check your vitamin D levels, all those part of the picture.
Yeah, I mean, at least a baseline, at least checking the vitamin D just to see where it's at. Some people will come in astronomically high and they're not doing much. Some people will come in astronomically low and they're actually taking something. But, screening you and I agree, but vitamin D screening in general is not endorsed. But you'd think that people on hormone therapy would at least know that number one time. And that's another thing that probably happens less than 10%. It's not just the DEXA scan.
Well, vitamin D, here we are in California, people get lots of sun. We see vitamin D deficiency that is below the threshold that is stipulated by the labs is what is normal in probably 15 to 20% of men that are just screened in the general population. So it's very common for people to be vitamin D deficient.
Well, speaking of something that adds to bone loss, and I just pulled this out of one of our journals. This is side effects of steroids, including prednisone. Can I read you this list? This won't scare anybody if they read this. Let's see, a round face, high blood pressure, high blood sugar, increased risk of infection, cataracts, glaucoma, bone thinning, fractures, adrenal crisis, thinning of the skin, bruising, stretch marks, poor wound healing, muscle weakness. That's it. You don't have to look forward to anything else but that. So now why in the heck am I being put on a steroid with abiraterone? Because a lot of men out there are on abiraterone, and they're being told to take prednisone, but they're hearing horror stories about prednisone. So why am I taking prednisone with abiraterone? Can you please tell me that?
Well, a little bit is good, and a lot can be very dangerous. The amount of prednisone that's being given with abiraterone is designed merely to replace the amount of cortisone that we normally make in our adrenal glands. So the company is recommending 10 milligrams a day to reestablish these levels. Same amount was oftentimes given with Taxotere as just a matter of course, which we don't typically ascribe to. But let's say we cut the dose in half and give them 5 milligrams of prednisone. Probably not going to see much of any of those side effects that you've described. There are other alternatives. There's a diuretic called Inspra that could be substituted for prednisone for people that are particularly concerned about it. And in some cases, that's what we do.
INSPRA.
Correct.
Yeah, so that's a really good point. It's like aspirin. If you take too much, it could put a hole in your gut. If you take a little bit, it can cause blood thinning and maybe prevent a second heart attack, right? So the prednisone that you're asked to take on abiraterone is so low, and I get nervous sometimes if men don't take it because they can run into the toxicity. The toxicity becomes more serious of abiraterone. Okay, let's move on from that topic. We're doing well. I'm giving you a B+ so far in this interview. CAR T-cell therapy, immune therapy. If you came to our conference, you have to admit a couple years ago, people were excited about all these different types of immune therapy. We'll talk about the ones you talked about in your talk. But where's this CAR T-cell therapy that was supposed to be so magical and save lives and do all these things? Is it really? I know in lymphoma and leukemia, it's been a game changer. No one's ever used that word before. I'm coming up with the terms game changer. But I haven't heard much in prostate anymore. I've just heard about it in leukemia and lymphoma. Can you give me an update?
It is powerful enough to bring about remissions in men with really bad prostate cancers. The problem is that you're looking at treatments that seem to have toxicity on the same level as like bone marrow transplantation in these elderly men who are heavily pretreated and don't have the same physiology that younger lymphoma patients have who can withstand that type of a hit. So I think that, I'm not an expert in CAR T-cell therapy, but I think right now they're looking at whether mitigating the dose can make this something that would have some practical use. But as things stand right now, though I have seen patients who have had their prostate cancer growth impeded by CAR T-cell therapy. In almost all cases, it just shelled them out as a human, and unfortunately, the treatment was at least as bad as the disease. Okay,
I appreciate your honesty on that. Let's stay within the immune category. Provenge is sort of the forgotten FDA-approved product. I don't know, you just don't hear about it discussed much, but Provenge is still something that you use. And when I listen to your talks, I always get the idea that the lower your PSA, and I think you mentioned that, right? Plus the earlier on when you're at CRPC officially, that's when you might see a benefit. Is that right, or is there something else to add to it? Because I just think that's still sort of the forgotten weapon in the whole game that you're involved in.
I think it's tragic, after this crazy brush with COVID that we've had, we've all heard all the excitement about vaccines and the pushback against vaccines, and you've seen the exact same problems in professional opinions about Provenge, which is like a cancer vaccine. And there's people who are strident believers and other people who think it's all a hoax. Sadly, to me, the evidence is it was approved with double-blind, placebo-controlled trials. It's not like it wasn't proven to prolong life. There are other problems beyond that. The other problem is simply the complexity and the nature of what, when I described this timeline of different treatments, you could see where we placed Provenge right after Lupron resistance is a tiny little window, because it's much easier for many times these patients are being seen by urologists. It's much easier for them to simply write a prescription and put these patients on a pill than put them through a somewhat involved immune process that Provenge entails. They have to go have plasmapheresis and get infusions, and urology offices aren't set up to do that. So much easier to put them on some Xtandi or Zytiga, which have magical anti-cancer effects. They go into remission, and by the time they start running out of gas on Xtandi and Zytiga, all of a sudden the cancer is so serious that they're really not a very good candidate for a vaccine any longer.
Well, let's say they were put on those drugs, and then they turn around and they talk to you and they go, wait a second, I'm 3 weeks on those drugs, Zytiga, Xtandi, and I want to do Provenge. What do you say now? Do you say
Oh, yes.
Do you say fine?
Let's do it. Yeah. Yeah, there's nothing that precludes you giving them at the same time. As we hopefully got across in the talk, that the complexities are not simply picking what to do, but whether or not they need to be administered in combination or not.
You use Keytruda, pembrolizumab, right? So this is another immune drug, and you talked about it in your talk. You said if you qualify with a certain marker from a test, you can deliver Keytruda, right? And you give it how often if someone qualifies for this immune boosting drug?
Well, the protocols are changing. Historically, we would give it every 3 weeks. Studies now seem to indicate you can give it every 6 weeks.
And you give this as sole therapy, or you give this as an add-on to everything else they're doing?
In the patients that we are giving Keytruda to, these are typically people with very early small amounts of metastatic disease that want to try and suppress their disease progression without having to block their testosterone.
Okay.
And in some cases, the Keytruda can be effective in that role.
Okay, let me go outside of FDA approval for a second, just think outside the box. You also talk about in your lectures oligometastatic disease, where people have a couple spots here and there. They could be in a certain region, they could be scattered, and you believe, I know you have a lot of patients that get radiated to that area and then they're fine for years and years. But the concept is, do you have people that get radiation to oligometastatic sites that also can potentially qualify for Keytruda, or because it would seem to be a natural fit to test the possibility of radiating these small sites and using that immune therapy early to put them in remission longer, or maybe this is a dream. What do you think?
No, I think the problem, of course, is that measuring outcomes with immune therapy, you're not always going to know what's working, and Merck Pharmaceuticals, who manufactures Keytruda, has been very generous in providing compassionate use Keytruda. So we have used it in that very role that you've described, and we've also used Provenge in that same role. So if people are undergoing Provenge, we often will consult a radiation therapist and say, hey, this man has, let's say he's got more than 4 metastatic sites, and normally speaking, we wouldn't radiate them all, but why don't we just radiate one of them along with the Provenge, because we know that can have an immunostimulatory effect.
Do you worry about oligometastatic disease, a couple of people getting radiation over and over again? Do you worry about radiation-resistant disease eventually when people get hit multiple times, or is that just something that happens with very bizarre tumors?
The amazing thing about modern radiation is that essentially 100% of cases, it will sterilize the tumor site, assuming the radiation is done professionally and appropriately in that area. So radiation-resistant, no. New spots that can show up, and then after some period of time where too many spots have been treated such that you don't have enough bone marrow reserve to keep in that path, that can happen. But radio-resistant disease, no. It's the radiation therapy, if it's given in a large enough dose, will sterilize the tumor 100% of the time.
And to end the topic on immune therapy, what are you looking for? Because I remember in the early days, Provenge did not cause a PSA reduction, even though it helped you live longer. Is that still true? That you don't see a PSA reduction with Provenge, but you can see benefit?
Well, no, it's not a matter of seeing benefit. Who benefits when they have a COVID vaccine? We can see in a large population study, before COVID vaccines came out, we had patients, 3 patients that died of COVID. And we had, throughout Southern California area, we had ICUs that were full of people on respirators because of the seriousness of the COVID. Since the COVID vaccines and the boosters came out, we have not had a single patient who's gone to the hospital. Of course, now, more recently, we have Paxlovid. But even without that, we were not seeing in individuals really serious forms, although people were still getting infected.
Yeah.
So the same thing is true, I think, many times with immune therapy in prostate cancer. One interesting example of how silently our immune systems work. This came up recently because a patient of mine needs a lung transplant, and he has a small tumor in his prostate. We've been watching for 10 years. It's never done anything. And the transplanter, who's going to be giving immune suppressive medications, said that you have to have that tumor treated in your prostate, because when I take your immune system away, that little tiny tumor could kill you. And you say, that's ridiculous. I had a patient who died who had a small tumor in his prostate, and they didn't know back then. And after he had, I can't remember what kind of, I think it was a liver transplant, he ended up dying of metastatic prostate cancer. So all these small little tumors that we say are so harmless are mostly harmless because our immune systems quietly and effectively can keep them in check for a long period of time.
Yeah.
But we don't have a way to really measure that, other than we know that, our immune systems keep 4 or 5 pounds of bacteria in all of our guts in abeyance, which is an amazing thing. There's like a bioreactor going on in our guts, and yet we live on for 70 or 80 years without infection.
I mean, the immune system is amazing. Sometimes it's sort of unappreciated, but you bring up a good point that made me think of a question, because we're seeing a little bit of an uptick in hospitalizations right now in COVID in September around the country. But if you follow the data and you follow practice, that COVID was especially harmful to the cancer population. There's much more higher mortality rate, higher hospitalization rate. So in this day and age, why wouldn't a cancer patient, especially a prostate cancer patient, get the latest vaccine and/or, when traveling, talk to their doctor about traveling with Paxlovid if they qualify, the antiviral? You have so many patients. I know a ton of people who go to Turkey, they go to Africa, they're traveling all the time, they're living their life, but they're not traveling with any antiviral medication, and they're dealing with cancer. So I don't know where the question is there, but this makes no sense to me.
Well, two things. One, 80 to 90% of our prostate cancer patients are essentially not metastatic. So there are the patients with metastatic disease, and that's what we covered in today's talk.
Yeah.
That's actually a minority of my practice. So the average prostate cancer patient is a more typical elderly man. But your suggestion that we should travel with Paxlovid, I think, is like kindergarten level obvious. I mean, it's a very effective antibiotic, and there are patients even here in the United States that aren't informed that if they test positive, and Medicare will pay for 8 tests a month. If you're over 65, you can test yourself twice a week for the rest of your life at the federal government's expense. And if you test positive and take Paxlovid in a timely fashion, I think you're going to abrogate almost all of the significant symptoms.
I just think, as you do, that the cancer patients should talk to their oncologists about traveling with it. I think it's to have this medicine. And if I had a dime, all cancer patients. If I had a dime for every person that found themselves in the middle of some island and then called me and said, "You're not going to believe this, I got COVID," and they're not traveling with Paxlovid or something, I'd have a lot of dimes. I mean, it's just unbelievable to me. All right, I dealt with that overall. Can we talk about chemotherapy? I only have 5 or 10 minutes, but I just want to cover a couple other topics. You know what people have told me that outside of you in oncology that have big practices like you? And this really surprised me. They've told me lately that their perception of chemo has gotten better with more approvals of drugs in the castrate-resistant population. And I said, wait a second, that's counterintuitive. We have all these new drugs. Why is your perception better? They said they've begun to appreciate its broad impact in that population. Do you want to comment on that? Because that may not surprise you, but that surprised me.
Well, the word chemotherapy, the word cancer, the word radiation. The radiation therapists really burned a lot of people, 20 years ago, and are still living down that reputation. The type of chemo that was given to people 15, 20 years ago was not that effective and was 5 times more toxic than what we have now in 2023. So it's a horrible word. And to counterbalance that is there is enough genuine efficacy, anti-cancer horsepower in Taxotere for prostate cancer specifically. And the toxicity, other than some brief hair loss and some transient fatigue after the injections, is just not that big a deal. So I think after 20 years of using Taxotere in men with metastatic disease, people are realizing that when it's used in an appropriate role, it's very effective and quite useful.
People know about these two, Taxotere and Jevtana, but you mentioned carboplatin. You don't hear that word very often except in other cancers. So can you just re-emphasize or bring me back up to speed? Are you using this often, or is this rare to use carboplatin? You're clearly using the first two a lot, and they have a great track record, but when do you add on this other drug or another chemo? Is this in rare circumstances?
So you talked about Taxotere, Jevtana. They're actually very similar medications. And the approval that Jevtana achieved when the FDA started covering it was based on a trial where men had already had Taxotere, stopped, and then restarted Jevtana. And they showed that the ones that restarted Jevtana compared to a placebo lived longer. And the idea was that, wow, there's actually more value in taxanes, these are both taxane-based types of chemotherapy, than simply giving it for a short period of time. That more extended time will actually help people live longer. But given the fact that it's the exact same medicine, or very close to the same medicine, it's logical to say, well, what other type of chemotherapy that works by a different mechanism could juice up the Jevtana if you are on your second round? It's always more worrisome to be on your second round of something than having an untreated person. Your response rates are going to be much higher in the untreated, whereas someone that's been previously treated, your response rates are going to be lower and the duration of response is going to be shorter. So it's very common for us to give both Jevtana and carboplatin when we use Jevtana. The use of single-agent carboplatin in our practice is not very common. So I would say that the primary role is to try and enhance Jevtana response rates by adding some carboplatin.
How long can a person be on chemotherapy before you say, this is not working or it's working? Do you know immediately within weeks? Do you generally wait out 3 to 4 months? What's your patient's level, and what should the patient level of the patient be in this situation?
No, this is a really good question, because I'll see patients that have been in other practices where they've been on treatment for 6 months and their PSAs have been rising throughout, and you're wondering, what are they thinking?
Yeah.
Unlike the immune therapy situation, which we described, and where PSA does not correlate or give you much indication as to how much you've accomplished, with Taxotere and Jevtana, it's immediately obvious what's working and what isn't. And the specific answer to your question is 2 cycles. So 2 injections of 3 weeks apart. Check the PSA a couple weeks after the second injection. And the PSA, if it had been previously rising, which is almost always the case, should at least be stabilizing.
Okay.
If it's continuing to go up in a unremitting fashion, it's time to move on. And the idea of just going on and on with something that's not working oftentimes really bothers me.
So the PSA is an excellent indicator with chemo. It's not an excellent indicator with Provenge. Is it an excellent indicator with Keytruda that we talked about, the immune therapy? I mean, or not?
No, I think it is.
Okay.
Yeah, I think with Keytruda we expect to see marker results if we're going to continue treatment, especially since it's a off-label indication. You can't keep giving a medicine that is perhaps only going to benefit 1 out of 5 people indefinitely, unless you have some encouragement or results in that individual showing that maybe this individual is in that segment of the 1 out of 4.
You used a word I haven't seen you use in one of your talks before. I mean, you emphasized it more than the previous talks I had seen, because we were talking about chemotherapy. You talked about Neulasta, and you said on your slide it prevents infection. And you said, you're implying that not enough people know about it and are on it. Fine, that makes sense. How does it prevent infection? What does this do? Why are you so excited about it? What does this drug do?
So one of the common side effects from chemotherapy, I mentioned hair loss and tiredness. In the past, we had other problems with chemotherapy, nausea, and that can be, I didn't mention that because the medications such as Zofran completely eliminate nausea. And then the other huge problem was lowering of blood counts, neutrophils in particular, with the result of those intestinal bugs that I told you about getting released into the bloodstream, where people could have life-threatening sepsis. Neulasta stimulates the bone marrow to produce extra white blood cells, and if it's administered at the time of the chemo, instead of seeing a drop in white blood cells to a very low nadir that stay down for 5 to 7 days and then recover, which is what we dealt with for much of my early career. Now we see a really brief and short spike such that I can't remember the last time we've seen an infection in any of our Taxotere-treated patients.
How long does it take for Neulasta to work?
So it covers a period, so the chemo is given on a 3-week cycle, and the typical timing for the low point, the nadir of the white count, is about 7 to 10 days after the injection of chemo.
Okay.
So you give the Neulasta at the same time as the chemo, and it keeps the white cell count up for about 2 weeks.
Okay. I have asked every speaker who is an oncologist or works with advanced disease this question over 20 years, except you.
Okay?
And I bet you don't know what it is, and this is why I have such power here. It's a great question, and I'm thinking the one person I probably should have asked was you, but maybe because I talk to you all the time, or we used to talk all the time until, this whole thing blew up on YouTube, and then suddenly, no one's got time for more yet. No, but seriously, I always asked everyone with advanced disease who dealt with it, what's the latest miracle you've seen? Because we always sometimes talk about non-responders. And can you just elaborate on that miracle? I know you've seen countless miracles. I never ask you that question because we talk so much, but I'm asking you the question officially. Let's stay in Positive Town here. Let's be the mayor of Positive Town. You see miracles. Can you remember the last miracle you've seen in treatment and give us a little bit of hint about what it was about and the circumstances?
Oh, I have a list on my desk because I need to publish these results. It's not a miracle, it's a list of miracles. And the miracle is more of a category than an individual. We never expected that we would be curing metastatic disease with some regularity. The training in oncology when I first got into this in the late 80s was that any metastasis translates into eventual certain death. So spread equals demise, and that of course is still true with a number of cancer types. In prostate cancer, due to improved treatment, improved detection, better scans, and aggressive early treatment, I'm going to have to publish the significant list of men now that are 4 or 5 years out after treatment for metastatic disease with recovered testosterone levels, undetectable PSAs, 4 or 5 years after their last treatment.
And these are people on all types of treatment, or just you're seeing this, or just?
These are people that usually at some point along the way had metastatic disease radiated. And they had some other, perhaps combination of chemo or hormone or immunotherapy to try and goose it, and who have never had their cancer come back. That is not uncommon in my practice, and it's totally unexpected.
So there's that synergism there, that combination. So are you to the point now where you look for these almost every few months? I mean,
Yes. Yeah,
I love that story. Yeah. I can't believe I never asked you that. That's my fault. But then again, like I said, we talk about...
It's a paradigm shift, and I think that the patients that I'm describing had to have been diagnosed with old-fashioned scans, whom we pursued aggressive oligometastatic therapy with spot radiation. So if we were able to accomplish that with crummy, old-fashioned scans, the degree of enhancement that we're going to see now with these modern PSMA PET scans, I think it's going to be dramatic. And I think it's going to change the way that we treat prostate cancer, in that we've been so much back on our heels being very aggressive with hormone therapy to go after micrometastatic disease, because we know that if it got momentum that they would eventually die. So men are getting 18 months of hormone therapy routinely. All you have to have is a Gleason 4 + 4 = 8. Well, now with a PSMA PET scan showing no metastasis, the idea of, well, why don't we just try and get rid of the 4 + 4, because we know that the PSMA PET scan will be correct 80% of the time. So 4 out of 5 of those men will stay cured if they have their primary tumor in their prostate radiated. And what about the 20%? Should we just let them die? No. If their PSA even starts to come up a little bit, we can find the disease with a PSMA PET scan and go after a cure on the second go-around. So then the people that really need the aggressive treatment get it, and the ones that didn't need it are spared it.
Let's talk about castrate-resistant prostate cancer. Let's talk about advanced disease, you can call it that, right? I just want to mention a couple biomarkers, because I've been looking at some papers before we decided to get together this time. and I just want to hear your comment, and then I'll go with the final question. You're always looking for a marker as it becomes more and more advanced. You're always looking for a marker for success, right? So there was a paper that came out recently that got a lot of attention, and I had seen you use this before in your practice. It said we should be looking more in CRPC patients at the blood marker chromogranin A. Do you agree with that? Do you want to explain that? Because everyone's always looking back on PSA, but PSA is okay. You're always looking for other hints that something's working. So whether it's alkaline phos, whether it's LDH, right? There's all these markers you and I have talked about. I was surprised to see this paper say chromogranin A, something I had seen that you pulled 10 years ago. I don't know if you still pull it. But do you have any comment on that marker at all?
I think that's just the tip of the iceberg. One indicator of multiclonal disease that is a end-stage phenomena in really bad prostate cancer. And there are other indicators besides chromogranin A, you mentioned them, LDH, these sorts of things.
Yeah.
Thankfully, we don't see that very much because we try and prevent things from getting to that level. Other things beyond the tumor markers that you mentioned to consider came up briefly in my talk: FDG PET scans, C11 PET scans, Axon PET scans. Because of the multiclonality of very advanced prostate cancer, if you just do a PSMA PET scan and it shows nothing, you can't just hang up your hat and say we're done, because if someone has a rising PSA, something's causing this. So we need to find out if it's a rare variant, and it can be detected not only with blood tests, but also with PET scans.
So it sounds like you're still incorporating all of these and more.
I'm devolving more towards the PET scans than I am toward the
leaning on these
the blood markers, because they're non-specific, whereas the PET scans are very targeted.
Another question I've asked many people in oncology, I just never asked you, because again, I take for granted that I know you very well. You know, you're like the older brother that looks up to the younger brother, me being the younger brother, right? And I'm sure you constantly adore me and look up to me as a celebrity, and I appreciate that thinking. But one thing I notice about you, and a lot of people do notice, and I'm not asking you to get specific, I'm asking you to be generalized here, because I've talked about it, is before we end today, you have been very consistent as a doctor in your faith, in your belief in a higher power, in your faith. We can call it religion, we can call it spirituality, we can tag it with whatever we want. I have found that has kept you steady and made you a better physician. And I have found it's the one topic in patients and in medicine that actually has data, whether it's quality of life in other areas, that we shy away from because we're too worried that that's going to be the hot zone, that that's going to get us in trouble talking about religion or faith. I don't think we should shy away from it. Can you just describe to me at the end here how important your faith is to you, and do you talk about faith and spirituality with patients still?
Yeah, I mean, in terms of important to me, we could talk for hours about that. But in terms of the struggle that patients are going through in their battle, I think there's two levels. One, of course, is being able to pray and believe that God can help you. I think the other thing is to look at the circumstances and take something positive out of the difficulties. I think that we're all, not just cancer patients, but humanity is characterized by difficulties. And sometimes we get a persecution complex and we think, why me, why me? And but successful people look at, well, how is this guiding me to a better life? There's a faith that forces bigger than yourself allow these difficulties to happen. And we know that our stubborn human nature doesn't allow us to just go out and, run our half mile and lift our weights and swim. We have to be motivated somehow. And I think that the circumstances of life motivate us to become better people if we turn it to a positive. So yeah, it comes up all the time, actually.
Yeah, I think that's well said. I think it's important as a practitioner to let people, I'm not saying sell it. I'm not saying sell the Kool-Aid, but to let people know that you think that's an important aspect of life. And it comes with certain benefits if you are a part of that. Now, if you choose not to be, that's your choice. But I'm really sorry that in the area of cancer, we've kind of stayed away from it because I think people fear it's a hot button issue. I don't think it's a hot button issue. I just don't think people can explain it well.
Yeah.
So I appreciate you sharing that. Now, on a lighter note, I worked with some very talented people at the PCRI to provide you with a tennis ball.
Hey,
I hope you're appreciative of this. This is not only a tennis ball. This serves another function. It's an advertisement that I know that you stand behind very much, and I want you to show the camera. It's a Pen 1, right? But it also comes with an ad that I know that you back up tremendously, especially when I'm talking to you. Do you want to guess what the advertisement is?
I have no idea.
Take a look.
All right. It's for what? Green? I love
The advertisement says, I love surgery. Hold on, get this in the camera.
I love surgery on everything but the prostate.
I thought you would really enjoy hitting that tennis ball, of course, because you know how much
Oh,
I love
yes, I
surgery.
can take out all my
right, so you can take it
frustrations.
out, right? Exactly.
Yeah.
So in one way, I look at it as a gift. In
That's
another
a
way,
big step for the child of a urologist.
I love surgery. I'm just
Yeah.
saying, even though I know you're not a big fan of it, at least you can hit it. You can take all your anger and frustrations out on it. What better gift is there to give? I was thinking about
very
giving you
thoughtful.
a car.
It's very self-sacrificial on your part. Yeah.
All right, listen, I am going to see you again, but I won't be in person. I love seeing you in person. I think it's great that we got to be together, and I'll see you soon, definitely. And this is going to be another great conference.
Thank you, Mark.
Thank you.
Yeah.